Fantastic. Do you want to start sharing your slides? I'll just do a brief introduction.
Absolutely.
Yeah. Welcome, everyone. It's just past 8, and we are delighted to have Tiffany Caza from Arkana Labs in Little Rock, Arkansas, presenting to us on membranous nephropathy and especially membranous lupus nephritis. Dr. Caza is an MD PhD. She's a nephropathologist at Arkana Labs. She just describes herself as, someone who's interested in medical education and autoimmune diseases, but she's done a lot of work and published in especially in membranous nephropathy, but in a lot of other fields as well. Apart from nephrology, apart from this pathology, she's also a fabulous artist. She creates wonderful pictures and images from biopsy pictures, and she says she's interested in kidney donation, and she went ahead and donated a kidney a couple of weeks ago. We are very fortunate to have her with us so soon, presenting on something that's very close to her heart on membranous nephropathy. Thanks, Tiffany.
Thanks so much for inviting me. Okay, so a couple of things I'm going to talk about today are histopathologic features of membranous nephropathy and membranous lupus nephritis, but primarily the new antigens that have been discovered in the last 5 years and how those were discovered, and then what clinical associations there are with the different antigen types. Membranous nephropathy is the second leading cause of nephrotic syndrome in many adults. The first cause of nephrotic syndrome is diabetic nephropathy, and in some populations, particularly patients of African descent, the second most common is FSGS. But of all comers, it's a very common cause of nephrotic syndrome. 70% of patients have positivity against the antigen phospholipase A2 receptor, or PLA2R. This doesn't seem to be the frequency of the biopsied population, though, because you can have a presumptive diagnosis for membranous nephropathy based on PLA2R serology in certain circumstances when patients have preserved renal function. And 30% of cases have other antigens or may have other etiologies that are driving the disease, which include autoimmune diseases like lupus, medications, and others. On a kidney biopsy, membranous cases tend to have thickened glomerular capillary loops, of which you may see the presence of spikes or holes on silver stain. That occurs when the membranous is fairly developed. This is the same case where you can see here on the subepithelial surface, you have electron-dense deposits, but there is extensive glomerular basement membrane remodeling in intramembranous deposits, which results in that non-agerophilia and silver stain. There's granular capillary loop staining for IgG, and that's characteristic and diagnostic of membranous nephropathy. It tends to be diffuse and global in many cases, and those are when you have membranous due to primary podocyte antigens, where you should see confluence along the glomerular capillary loop. Some other types of membranous have a segmental or incomplete global pattern. There are several antigens that have been identified in membranous that are expressed within podocytes, and so you should have IgG staining along the glomerular capillary loops within a global pattern, and then that should correspond with your ultrastructural findings as well. Membranous nephropathy also tends to show complement deposition in the same distribution as you see IgG staining. And so here is IgG and C3 from the same case, from a case of PLA2R positive membranous. And many other antigens will have bright C3 staining as well. But I bring this up because there are two antigens in particular that may lack C3 staining and have different complement profiles. And until a couple years ago, or I guess until about 5 years ago, the antigens phospholipase A2 receptor and thrombospondin type 1 domain containing 7A or THSD7A were the two known antigens in membranous. So these cases were considered primary, and then everything else was considered secondary. You should see staining for PLA2R or THSD7A in the same distribution as you would by immunofluorescence. But we're trying to get away from primary versus secondary membranous nephropathy because secondary etiologies of the disease are now being associated with particular antigen types. So according to the KDIGO 2021 guidelines, if patients have PLA2R negative membranous, you'd want to look for secondary etiologies of disease. These could include malignancy, autoimmune disease, sarcoidosis, medications, and infections, for which several are associated with autoantigens that we'll describe. And it's important to identify an antigen for a number of reasons. One of them is non-invasive monitoring of disease activity. That's available currently for PLA2R and THST7A, but not other antigen types. For PLA2R, there's both an ELISA and an indirect immunofluorescence assay that's available, and the ELISA is FDA cleared. And antibody titers will correlate with disease activity and are useful for monitoring treatment. And this testing has such high sensitivity and specificity that it can be used for primary diagnosis for PLA2R positive membranous. So if you have PLA2R positivity, and that should be by both ELISA and indirect immunofluorescence assay to prevent false positives. I'd recommend doing both tests at the same time, but if both are positive, a patient has a normal GFR and they don't have another reason to have proteinuria, such as diabetes, they may have a presumptive diagnosis of membranous. If they have low renal function or comorbid conditions that could be responsible for their proteinuria, those patients should still undergo a kidney biopsy. And with serologic testing, antibodies precede disease activity, and that's before the initiation of the disease itself, as well as for a disease flare. Titers will correlate with proteinuria, but the antibody titers will fall prior to the proteinuric response, since you have those immune complex deposits within the glomerular basement membranes that require remodeling. The antibodies will drop with treatment and rise prior to disease activity, and that's really important because it could prevent having clinical flares. You could have serologic recurrence, but you could treat at the level where you don't have a lot of end organ damage from a membranous flare. Antibodies can also correlate with disease activity in secondary drivers, and this has been shown with THST7A membranous. THST7A membranous in a small proportion of cases may be associated with malignancy, and that's from copy number increases for THST7A that is present within some tumors. But THST7A antibodies have been found to correlate with not only activity of the patient's membranous, but also the underlying malignancy. And testing has high sensitivity and specificity, and if it doesn't, it wouldn't really be that useful. Another advantage of identifying a target antigen is to identify disease triggers, and that could include malignancy, autoimmune disease, or certain medications and supplements that are potential triggers for the disease. And some of these medications and supplements are not common, and some are alternative medicines that may not be in a patient's medication list. So it could help you look for those potential etiologies. And so about 30% of membranous cases are negative for PLA2R and THST7A, and this is about 45% of the biopsy population is negative for PLA2R and THST7A. So you have a case with some granular capillary loop IgG staining consistent with membranous. It's PLA2R and THST7A negative. So what are these? There's multiple methods we can use to identify what those remaining autoantigens are. And these have been employed. These same techniques can be used for other autoimmune diseases besides membranous nephropathy. So the first membranous antigens, and some recent ones too, were identified through serum immunoprecipitation with glomerular extract. So you would have sieved glomeruli, for which you create a protein lysate, and you react with patient sera, run out an SDS-PAGE gel, and then use patient sera as a primary antibody. The secondary antibody would be an anti-human IgG, and normally you shouldn't have reactivity with a glomerular protein with antibodies in your sera. And so having reactivity is abnormal. You can run a SDS page gel at the same area of your Western blot, cut it out, and do mass spectrometry. And this is how PLA2R was identified, also how THSD7A was identified, as well as a couple of the new autoantigens too. A caveat of using this technique, though, is that you require the protein of interest to be in the glomerulus. If it's not a podocyte antigen or not a protein that's expressed within glomeruli, you're not going to see any seroreactivity by this technique. And so to get over this hump, tissue-based techniques have been used using a kidney biopsy to identify the antigen type. And laser capture microdissection is one of the most common. So we take residual kidney biopsy tissue and take these thick, well, 10 micron sections, and you put them onto these membrane slides, and then cut glomeruli out with a laser, do trypsin digestion into peptides, and then run liquid chromatography and mass spectrometry. This will enrich for your target of interest by at least 50-fold, as you're getting rid of the tubular, the effect of the tubular interstitium and such. But it's not specific to the immune deposits. So you need comparisons to controls of other antigen type as well as other diseases. And this was used to discover several autoantigens that we'll describe further. Another method is to do protein G immunoprecipitation with frozen biopsy tissue. So instead of using the paraffin tissue, you can use the frozen tissue and make a protein lysate. Expose it to protein G, which binds immunoglobulin that you can elute from the kidney biopsy specimen, and then you can interrogate those eluted immune complexes. And that's been used for discovery of autoantigens, and this is the technique that we use at Arkana. And what the data looks like is that we'll plot it out on a volcano plot where you have your high fold change or low p-value is going to be in this upper right corner. And so this is a case where you had PLA2R positivity, and then this is just immunoglobulin heavy chain. You're going to have a lot of immunoglobulins in this plot, since protein G is going to pull out the immunoglobulins. Here's a THSD7A case, and so on. And so there are a lot of antigens now in membranous that are not directly associated with autoimmune diseases. So we'll go through some of these, and I apologize if it becomes a little bit like alphabet soup, but there are a lot of antigens that are now described in membranous, and there's a couple that might be more important than others at this time because we need to gather more data to see the importance of some of these rare ones. So one of the more important new antigens is neural epidermal growth factor like 1 or NELL1. And this was an antigen that was identified through laser capture microdissection and mass spectrometry. When you have a putative target, you want to perform an immunohistochemical stain that should show the same distribution similar to PLA2R that you have in the immune deposits. For discovery, you'll use colocalization with IgG to show that they exist within the same part, and then to identify a candidate protein as an antigen itself, you want to detect serum antibodies as well, of which have been detected. You have seroreactivity against NELL1 recombinant protein. This was described at the Mayo Clinic in 2019. And NELL1 associated membranous can be picked out in kidney biopsies quite easily, actually. There tends to be this capillary loop sparing, and that's seen in a total of 94% of cases. We'll have a lack of complete and global granular capillary loop staining. A lot of them are not purely segmental, where you would have less than 50% of the glomerular capillary loops with immune deposits, but incomplete global staining is quite common. They can see here with IgG and NELL1, as well as an ultrastructural photomicrograph where you have immune deposits and a loop without. And of all cases of segmental membranous, the converse, NELL1, would be the most common antigen. Reasons to look that NELL1 identification of NELL1 is important. It's increased in the setting of malignancy. We did a study at Arkana where we found 91 NELL1 positive patients. We also looked at PLA2R and THSD7A disease controls and found that 1/3 of patients with NELL1 have a concurrent or active malignancy or malignancy associated. And these include carcinomas, melanomas, thymomas. There wasn't a particular type of cancer that was related to NELL1, and we currently don't know the mechanism for which there's an association of NELL1 membranous with malignancy. THSD7A had an increase, or patients had an increased rate of malignancy, of which has been described earlier. And for PLA2R positive membranous, there likely isn't an increase. And these 4% of patients likely is the background rate of malignancy in the general population. And the mean age for development of PLA2R positive membranous is 58 years old. Similar for THSD7A, but for NELL1 membranous, patients present a little later, usually in their 60s. Malignancy-associated membranous proteinuria should correlate with the underlying malignancy. So as the tumor grows, you should have a rise in proteinuria. As you have a metastasis, it should rise. And with successful therapy, it'll fall. However, your proteinuria will rise before it falls, because if you have successful treatment by radiation therapy or chemotherapy, not so with resection, but you're causing tumor lysis and the presence of that antigen in the periphery. So another association with membranous are traditional indigenous medicines. So in the United States, I'd imagine it's probably similar in Canada. 5 to 8% of all membranous patients are NELL1 positive. So this ends up being about 20% of cases that are PLA2R negative are NELL1 positive. In China, and in India, and in Japan, it's been shown that NELL1 membranous has a much higher frequency. So in India, there's a study at Renopath, which is a large center in southern India that receives biopsies from multiple practices. And in their practice, they saw 35% of their total membranous patient population was NELL1 positive and also had association with traditional indigenous medicine use. So in patients that were on these indigenous medicines, 88% were NELL1 positive. When you look at patients without indigenous medicine use, you get the rate that we see here in the US. So I'm not sure if this is similarly occurring in China and Japan, or if there are other factors that are responsible. But this is a consideration, particularly in patients that might be receiving native therapies. And unfortunately, this is related to chronic mercury toxicity, as some of these medicines have heavy metal poisoning. There are other causes for mercury toxicity that have been associated with NELL1 membranous. There's a recent paper about skin whitening creams with NELL1 membranous, where mercury is used to inhibit melanin production and has been an inciting factor. Fluorescent light bulb recycling is a source of mercury exposure that has been shown in a rare case report. Chronic exposure is thought to be responsible for membranous. Mercury poisoning has also been associated with minimal change disease, which has been usually a faster high dose exposure. Lipoic acid is another medication that has been associated with NELL1 membranous. So there's this interesting study where in 2 different clinical trials of patients with multiple sclerosis that were taking lipoic acid for neuropathy, had developed proteinuria and were biopsied and found to have NELL1 membranous. And having patients with that same disease etiology within a clinical trial, so a very rare form of, or a very rare cause to have proteinuria within the same trial raises suspicion. So lipoic acid was discontinued within those patients, and they responded without requiring immunosuppression, establishing a potential link. We looked at the frequency of lipoic acid supplementation in the membranous population in Arkana, and in NELL1 positive patients, 14% were taking lipoic acid. And besides multiple sclerosis, and actually we didn't see any patients with multiple sclerosis, they're nearly all diabetic patients, as those patients develop neuropathy. So it's a consideration to remember, and lipoic acid could be taken over the counter and whole food suppliers, and so this may not be in a patient's medication list. Two recent associations are butylamine and tiotropium, which have been associated with NELL1 membranous. Butylamine is a disease-modifying anti-rheumatic agent, and tiotropium is used to treat cystinuria. Both of these drugs, as well as lipoic acid, have these thiol groups, which are thought to be potentially a common mechanism within these inciting membranous nephropathy. NELL1 membranous is not typically seen in membranous lupus nephritis. However, if patients are taking lipoic acid or butylamine for treatment, that can be seen. Another antigen in membranous is semaphore 3b, and this was described at the Mayo Clinic as well. This is an antigen that is increased in the pediatric population and is seen in about 10% of all pediatric membranous as semaphore 3b positive. Pediatric membranous nephropathy has a different distribution as adults, in that only about 30 to 35% are PLA2R positive. You have a lot of patients that are positive for a different autoantigen, axistocin, and then about 10% are semaphore 3b positive. Compared to adults, the amount of cases of semaphore or of pediatric membranous nephropathy with an unknown antigen is increased. But this type of membranous will have features that are seen in secondary-like membranous with tubular basement membrane deposits or C1q staining. It's important in that this type of membranous has a good prognosis. A follow-up of a total of 10 patients, 9 of them went into complete remission, some spontaneous remission. And here's what one of those biopsies looks like. There typically is no significant tubular interstitial scarring, which is associated with that good prognosis. You may have mild mesangial expansion, but often don't. And it's usually caught early, so maybe especially toxic to podocytes, and that you typically catch this disease with stage 1 immune deposits. Intense C1q staining is very common, and just here's a semaphore 3b stain that shows similar pattern to IgG here. Another membranous antigen is H-cherry1. This has been identified by serum immunoprecipitation with human glomerular extract, laser capture microdissection, protein G immunoprecipitation, as well as peptide microarrays. And this type of membranous affects older individuals, but currently there aren't known associations of certain disease states with H-cherry1 associated membranous. Antibodies, however, have been detected in serum and correlate with disease activity. So here's a patient where proteinuria had fallen, and you have restoration of serum albumin, and you have a reduced serologic response. So this is patient sera reacting with the H-cherry1 recombinant protein. This is a podocyte antigen. It's expressed here in podocytes, and here's H-cherry1 in a podocyte cell line. Protocoherin 7 associated membranous. This was also described at the Mayo Clinic. There's limited data right now, as only 10 patients have been described to date. But something important to remember in this instance is that there are low staining and spectral counts for complement proteins. So normally you should have C3 in the same intensity as IgG, but that's not the case for protoconherent-associated membranous nephropathy. They also have IgG predominant immune deposits. For PLE2R and THSC7A membranous, immune deposits are IgG4 predominant. But currently, it's becoming less useful to do IgG subclasses in the setting of membranous, as multiple antigens are now of the same subclass. It doesn't help you distinguish between primary and secondary etiologies as well as it used to. NELL1 is also IgG1 predominant too. And FAT1 associated membranous, similarly to protoconherent 7 associated membranous, is a protoconherent protein. And this has a unique clinical situation, and that is seen in the setting of hematopoietic stem cell transplant, where the majority of cases of hematopoietic stem cell transplant associated membranous are FAT1 positive, and this is associated with chronic graft versus host disease. And the incidence of having hematopoietic stem cell associated membranous is 0.6% of the transplanted population, which is really high. But multiple glomerular diseases are increased in patients who've undergone a hematopoietic stem cell transplant. And membranous is the second most common there, the primary being thrombotic microangiopathy. Here's a case of FAT1 associated membranous. Typically, there is a worse prognosis and increased tubular interstitial scarring compared to other membranous cases, and that may be associated with active interstitial inflammation in chronic graft versus host disease, or you may have the sequelae thereof where you have leftover interstitial fibrosis and tubular atrophy. There tends to be no glomerular proliferation, and C3 will have decreased staining similar to protoconherent 7. You typically catch early immune deposits of this for this particular antigen, and here's a volcano plot for FAT1 for one of our cases. We don't have that antigen brought up at Arkana yet. Netrin G1 is a new antigen in membranous, and there's only been 3 patients described to date of 888 patients tested in a cohort, and this was through serum immunoprecipitation with human glomerular extract led to identification, but we need more data to see if there's any clinical associations that come out of this and exist. Neuron-derived neurotrophic factor is a type of membranous that is seen in patients with syphilis. So there was, this was a study at the Mayo Clinic, looked at 250 patients, of which 5 or 2% in total had NDNF-associated membranous, and these patients all had syphilis, which resolved with successful treatment. A new antigen described in membranous, and this was a collaboration with Arkana and Dr. Sethi at the Mayo Clinic, was NSAID-associated membranous, and that's from PCSK6 is the target antigen. And so they identified it by laser capture microdissection. We had by protein G immunoprecipitation. There's co-localization with IgG, showing that the potential is a target antigen, and antibodies were identified. And the majority of patients had a history of heavy NSAID use, particularly meloxicam, of which the membranous resolved with stopping the drug. For NSAID-associated membranous nephropathy, this will be one antigen, but their NSAIDs are so frequently used, and not all patients with NSAIDs are going to have PCSK6 membranous, but this is an antigen that, if identified, could indicate that NSAIDs are a potential etiology. At Arkana, we identified 7 new antigens, membranous nephropathy and membranous lupus nephritis. These are potential antigens that we're still looking for antibodies present in serum. And that's particularly because we identified these during the pandemic, where patients weren't going out for phlebotomy, so it was very hard to recruit in that instance. But we did protein G immunoprecipitation to identify target antigens. You want to see multiple peptides responsible for that protein and exclusivity with other proteins. Showing confocal co-localization can give you confidence as a candidate, and then you can determine the frequency by taking a biopsy cohort, staining for the antigen, and seeing the number of cases in total. That led to identification of more targets in membranous lupus nephritis now, and to a lesser extent, non-lupus membranous cases. There were also several putative antigens that were identified at the Mayo Clinic around the same time, which we also don't have serologic data for the same reason. Altogether, these are probably less than 10% of PLE2R membranous cases. However, it's helping decrease the knowledge gap for membranous lupus nephritis. So hopefully there'll be more to come with these. Now I'm going to move on to some antigens that are in membranous due to autoimmune diseases. And the most important here is the exostocin-1 and exostocin-2 complex. But there's some others that we can discuss as well. So overall, kidney involvement is super common in patients with lupus, with up to 60% of patients developing nephritis. And so this affects about 300,000 patients in the United States alone. And lupus nephritis can be one of the first manifestations of lupus. So if you have membranous nephropathy in a young woman with a positive ANA, you have to really keep lupus nephritis on your radar. Membranous due to lupus, though, can look very much like idiopathic membranous nephropathy. So how do we distinguish membranous lupus from membranous lupus nephritis? And this is actually a case of NCAM-associated membranous lupus nephritis. But you see thickened glomerular capillary loops, you have presence of spikes and holes on silver stain. This could have an identical appearance to PLA2R positive membranous, for example. But some clues would be immunostaining for more than just IgG and C3. Having had the heavy chains IgA and IgM are less common. Intense C and Q staining is less common in non-lupus membranous. And you can have a tissue ANA reaction, so IgG staining nuclei throughout the kidney biopsy, which happens within tubular epithelial cells and within podocytes. Similar to what you see with HEP2 cells in culture for measuring anti-nuclear antibodies. So full house staining doesn't occur in all cases, but when seen, it's going to increase your suspicion for membranous lupus nephritis. Extraglomerular staining would be another reason to increase your suspicion. And here we have tubular basement membrane deposits, and this is IgG by IF, and some electron-dense deposits ultrastructurally. Another clue is having mesangial deposits. That's nearly ubiquitous in membranous lupus nephritis. The majority will have mesangial deposits, although other types of so-called primary membranous also have mesangial deposits. Tubular reticular inclusions around the subendothelial surface of the glomerular basement membrane, and that is seen with interferon exposure. So there's a high interferon state in lupus, so that might be a factor you see in autoimmune disease, but viral infections will show the same, a main one recently being COVID. Having staining for multiple IgG subclasses is seen in lupus. When PLE2R and THFC7A membranous or IgG4 predominant, you usually have all 4 subclasses staining in membranous lupus nephritis. And so this is a study from Columbia, and it's been shown if you have 3 of any of those features, you have a 95% of the membranous being due to lupus. And if you have all of these, there's a very high suspicion that this patient has lupus. So the most common antigen that's known to date for membranous lupus nephritis is the exostocin-1, exostocin-2 complex. This antigen is seen more commonly in patients that are females of childbearing age. They typically have normal renal function, but present with nephrotic syndrome. A majority of these patients have a positive ANA, may not carry a diagnosis with lupus at the time of biopsy. However, given that they now have a history of nephritis, a lot of them are now found to have a diagnosis of lupus. And the reason to look for exostosine in cases of membranous lupus nephritis are really twofold. If patients don't have a history of lupus, this antigen could help you get there, as more than 80% of cases of EXT membranous have an associated autoimmune disease. And another reason is this antigen is associated with a good renal prognosis. There were two studies that were performed that had looked at lupus patients with EXT2 positivity retrospectively for a 10-year period, and patients that had EXT positivity compared to EXT negative patients had a very low risk of developing end-stage kidney disease. It was about 3%, so it's associated with a good prognosis. Here's a case. You can see low chronicity. Here's a IgG stain that has some mesangial as well as capillary loop staining in that tissue ANA reaction. You can see some intense C1q staining, as was seen with the features of membranous lupus nephritis. We typically don't catch EXT membranous when you have stage 1 deposits, although you certainly can, but it's not infrequent to have intramembranous deposits at the time of recognition. And you can confirm by immunostaining for EXT. Kidney biopsy features include having low chronicity as well as staining for multiple immune reactants. And the majority will also have these mesangial immune deposits. NCAM1, a neural cell adhesion molecule 1, is a type of membranous. It's identified here at Arkana by protein G immunoprecipitation, and has a very similar presentation to EXT membranous. These are patients that are young females of childbearing age, typically have normal renal function and nephrotic syndrome at presentation. There may be a potential association with neuropsychiatric disease, but we need further data to establish that. NCAM1 is expressed both within neurons and podocytes, and 40% of patients in this small series of only 20 patients had neuropsychiatric lupus, which would be seizures, cerebritis, or psychosis, compared to 9% of the lupus population overall. So there could be a link, but there's more data that needs to be collected to determine that. Here's a case of NCAM1 associated lupus nephritis. Having proliferative changes for which you have either a focal or diffuse lupus nephritis in addition to membranous lupus nephritis is pretty common. And here's some endocapillary hypercellularity and crescents. This can occur in about 1/4 of cases where you'll have a concurrent proliferative component. Having staining for multiple immune reactants and tubular basement membrane deposits are common, and then you can use NCAM1 immunostaining for confirmation. There were very similar findings as EXT-associated membranous, although these aren't associated with as good of a renal prognosis and sometimes have some background chronicity that is present. CGFBR3-associated membranous, similar to both EXT and NCAM1, had similar demographics and presentation, being young females of childbearing age with normal renal function and nephrotic syndrome. With a high association with lupus. And these histopathologic features are also nearly identical to EXT and NCAM1 associated lupus, membranous lupus nephritis. Overall, all three of these can occur with a proliferative component. So in addition to membranous lupus nephritis, you can have a focal or diffuse lupus nephritis in about 1/4 of cases. These would be associated with a worse renal prognosis, but even EXT cases with a proliferative component tend to do pretty well. Contactin-1 is a new antigen that has been described in a very elegant study. They looked at 1,500 patients with chronic inflammatory demyelinating polyneuropathy or acute polyneuritis, which I think it would be impressive to get a serum bank of this number of patients. And look for Contactin-1 antibodies, and those have been previously described in case reports to be associated with CIDP. And of patients with Contactin antibodies, about half of them develop membranous nephropathy. So although it's a rare etiology for CIDP, if patients have Contactin-1 associated CIDP, there is a high rate of development of membranous nephropathy. And this was seen by serum immunoprecipitation with both human glomerular extract and human brain extract, where you can see a co-localization with IgG for Contactin-1, not only in the glomerular immune deposits, but also in T's nerve preps. That's not an antigen that we've seen yet in membranous lupus nephritis, but it's seen in the setting of CIDP. Some cases of membranous can have light chain restricted deposits. It's typically more commonly kappa than lambda, but it could be either. And if you ever see a membranous that has light chain restriction, the next step would be to do IgG subclasses. And this is a situation where it's important to do IgG subclasses in a membranous case. Because if you only have one IgG subclass as well as one light chain, they're isomonotypic deposits, of which could be clonal and be due to an underlying malignancy. So in some circumstances, these could represent an MGRS lesion. If they're biclonal, or if these cases are PLA2R positive, they're much less likely to represent a hematologic malignancy. So now we're moving toward an antigen-based approach to classification of membranous rather than primary versus secondary. And the overall incidence of some of these antigens that we've been describing is a PLA2R, again, is the most common, but NELL1 is then the second most common, EXT, although mostly represented by membranous lupus nephritis, and these other antigens make up 1 to 5% of cases each. Localization of the immune deposits could be helpful to know what antigens to look for. If you have diffuse and global granular capillary loop staining for IgG, you can think about being due to a primary podocyte antigen. If there's mesangial in addition to capillary loop staining, these are typically seen in autoimmune disease. Having incomplete staining is seen in NELL1. It's also seen in membranous that's associated with other conditions. Membranous can be associated with ANCA-associated glomerulonephritis, for example, with MPO antibodies. You can have a segmental membranous in the setting of anti-brush border antibody disease, and in some cases of graft versus host disease and FAT1-associated membranous have a segmental staining pattern. Tubular basement membrane deposits similar to the mesangial staining are seen more frequently in membranous lupus nephritis. Some histopathologic clues as an overview to look for is if you have segmental staining, think NELL1. If you have multiple immune reactants, think membranous lupus. If you have C3 staining that is weak to absent, think about protocoherent proteins as being responsible. And mesangial and tubular basement membrane deposits, if you have other features, increase your likelihood of being due to membranous lupus nephritis. Here's a potential algorithm for staining for membranous cases. This is not very practical in clinical use, but if you have a membranous case that's PLA2R positive, you can consider it PLA2R positive membranous and just stop. Dual positivity for antigens is quite rare. If it's PLA2R negative and you have an autoimmune history such as a positive ANA, you can think about doing the membranous lupus antigens. A segmental pattern for IgG, it's important to do NELL1. If you have diffuse and global staining, a lot of those antigens will have the same staining pattern. For children, CMA3B staining is important, as well as EXT1 and EXT2, as these are frequently associated with autoimmune diseases. There are other rare etiologies in children as well. Monotypic membranous, you should do IgG subclasses to rule out a clonal process. Another consideration is membranous-like glomerulopathy with masked IgG kappa deposits. If you have cases that are IgG kappa restricted, the antigen here is serum amyloid P. And then you can look for other etiologies. We're starting to see some antigens with infection. Hepatitis E antigen is seen in hepatitis B associated membranous NDNF in the setting of syphilis, for example. Medications, we have seen PCSK6 membranous with NSAID use, as well as lipoic acid, butylamine or tiotropium, and indigenous medicines with NELL1 membranous. De novo transplant-associated membranous in the setting of antibody-mediated rejection may be due to the donor-specific antibodies itself, but we don't have a good etiology yet for those cases. And then immunodeficiencies are another consideration, particularly in children. So here's a strategy that has been proposed at the Mayo Clinic, and that's if you have PLA2R negativity, look for potentially actionable antigens. Then there's the less common antigens and the putative antigens. I would suggest not looking for all these putative antigens in a regular membranous case, and in your standard workup, PLA2R negative cases, I think it's a good idea to reflex to NELL1, THSC7A, and EXT1 and 2. And for the remaining, I think we need further data. So in looking for potential actionable types of membranous, those antigens are important due to the potential etiologies that we were describing. Here's some associations with antigen type. And you can think before there's primary versus secondary membranous, with secondary being related to malignancy or autoimmune disease or medications. Now we have antigens that are identified with those potential associations that again gives us a good rationale to have membranous described as antigen type rather than primary and secondary. And these are two interesting types of membranous. In young infants that are exposed to cow's milk-based formulas, you can develop a serum sickness-like reaction with membranous due to cationic bovine serum albumin that will resolve in stopping the formula or changing it. In the setting of membranous occurring at birth could be due to anti-neutral endopeptidase antibodies by mom being deficient in neutral endopeptidase, being sensitized by neutral endopeptidase from the fetus, from the father. And the antibodies cross the placenta and results in membranous nephropathy in utero, where you can even get oligohydramnios. At birth, there's severe nephrotic syndrome that requires albumin transfusions frequently. You could do plasmapheresis, but it's hard to do on, teeny tiny babies. But the disease will resolve on its own, and that the fetus is not making those antibodies. They're from maternal antibodies. So those patients, unfortunately, can't breastfeed though. And so here's a look into the future. If you have a PLA2R negative membranous case, mass spectrometry might replace doing multiple immunostains. It's not practical at this time, but it's under development both at the Mayo Clinic and at Arkana for typing of membranous cases. And so as an example, if you have a PLA2R negative case, you can run mass spectrometry for a tentative ID. You can then do immunostaining confirmation for just that one antigen. And that could help you identify what are potential clinical associations. And in the future, hopefully have a baseline antibody titer once we develop serologic assays for multiple types of membranous. And the main issue there is that they're just newly described. You have to recruit a lot of patients with rare disease to donate blood at various portions of the disease course to develop these assays. But I think 5 years from now, they should be available for multiple antigens. And that's it. I'd like to thank Arkana. Particularly, so Dr. Clarissa Casal was my mentor in residency back in New York, and she came down here at Arkana, and it's awesome to have a mentor become a colleague down here. And Dr. Chris Larson, who we do a lot of research together, and he's also our leader here at Arkana. And thanks for your attention today. I'd be happy to answer any questions.
Thanks, Dr. Caza, for that wonderful overview of all the antigens and the associations. And it's great work you guys have done at Arkana as well as the Mayo Clinic people. If people have questions, please raise your hand and unmute yourself to ask questions. I can start with some, some basic questions. So you mentioned that in idiopathic, again, we don't want to think about it that way, but maybe there are 10% which are unknown. In the membranous lupus, do the exhaustion and the others comprise the majority of the antigens, or do we is there still a lot of unknown in the autoimmune membranous lupus?
So exostosin-associated membranous is 1/3 of cases. It's 31 to 33%. Some of NCAM1 is 7% of membranous lupus. TGF-br3 is 5.5%. Some of these rare antigens are putative antigen types, for example, EA1, phycolin-3, visorin. They've been associated with membranous lupus, but of a smaller capacity. But there's still at least 1/3 of cases that are not typable for membranous lupus, but we're starting to close that knowledge gap, similar as in so-called primary members.
Fantastic. It's useful. Oh, Mark has a question. I'll let him go first.
Thanks, Bob. Thank you very much, Dr. Caza. I really enjoyed that talk. I think I'm gradually understanding this a bit more, but it seems, like every 5 minutes I get a new alert to say that Dr. Sethi has found another antigen, and I struggling to keep up a little bit because I just got my head wrapped around PLA2R and how to sort of track it and manage it. So I think most of us are struggling a little bit with what to do. And I guess, while it's clearly you made a compelling case for why it's important to find these antigens in terms of monitoring disease activity or refining your search for a known causative disease association. I guess two things. One is that it doesn't obviate the need to look for stuff, in the sense that, if it's a 1 in 3 association, it means that in 2/3 of cases, you still got to look for your cancer or whatever. And then the second issue is that, when it comes down to it, we still, both in clinical practice and in enrollment in clinical trials, we still say, are you on an ACE inhibitor? Do you have more than X amount of proteinuria? You're getting treated with these 3 drugs we have, or you're going into a trial. And so, and I would draw an analogy with IgA nephropathy. Like, we have this really amazing science describing disease pathways and unique pathogenesis, whether that's complement mediated or through, some other pathway. And then when it comes down to it, we still just say, like, have you had a fairly recent biopsy? Do you have persistent proteinuria? And so I guess what I'm getting at is, do you think at some point we'll be able to refine things to the point that it'll impact choice of therapy, duration of therapy, because that's really where it has to go, I think. And one thought I had when I was listening to you was, you could maybe do this in a post-hoc way, because there are some obviously recent clinical trials in membranous. It's hard to recruit, and it's going to be hard to do big studies. But maybe you could look back at the tissue and other biospecimens you have that are still stored from those trials, and just have a look and see, like, is there any signal there about response to therapy or outcome during a clinical trial? Just at least then it's in a controlled setting, and you've some, because otherwise you've got a small sample, and if you do it in a retrospective observational way, you've got this massive selection bias for treatment. I'm just trying to figure out how it can go from that's pretty cool to know to how is it going to change what we do?
No, those are absolutely great points, and I think that's really important to look back at clinical trials and type those cases, and would love to have collaborations to do so with investigators within those trials. But no, I completely agree with you, and that patients that are PLA2R negative need the extensive workup, really not necessarily restricted to the antigen type. And I think that it'll be most useful once serologic testing is available for all of these. If we can't monitor it right now, I don't think it affects clinical practice that much. It is an academic exercise for a lot of these. I think EXT and NELL1 are helpful, THSD7A, because there's serologic testing available right now. But testing for all of these is really not practical. But multiplex approaches could help identify cases. But currently, that is still really an academic exercise until there is something that's actionable and we have meaningful, large enough cohorts to know that there are definite associations that exist. But you need to find those patients to develop those tests, which we're working on here at Arkana. They're working on the Mayo Clinic and really needs a lot of multi-institutional collaboration to develop those assays in the first place. Because if you have 3% of all membranous cases are due to a certain antigen, it's really going to be hard to develop a test for it. Because it's not only detecting antibodies, you want to know that it correlates with proteinuria, that it resolves with treatment response. It's not a very useful assay if it doesn't have the same performance characteristics like PLA2R does. So in the future, that's where I see things going, but treatment response to certain therapies in trials or currently established treatments is a great point and is important to know.
Thank you.
Thanks for that question, Mark, and for the answer as well. Anyone else have any other questions before we wrap up? No, it looks like this has been a fantastic overview of the antigens again. We are looking to a brave new world where we will finally be getting all these antigen testing. And I understand, it's one thing to say, hey, there's a patient with a malignancy, so we should be looking at this antigen, but often the finding the antigen is what triggers a search for a malignancy or for the indigenous medications or what have you, right? So to me, that's the attraction of getting of having access to all these antigens so that we can dig deeper into the history in a focused way, perhaps. But with that, we'd like to conclude this session. Thank you again, Dr. Caza, for presenting that marvelous overview of membranous antigens. We look forward to more research from your group and more papers on this topic and other topics as well. And it'll be wonderful to have you and meet you in person sometime in the future. And for the attendees, there's Peter wants to say something. No. Okay, you're just saying bye. And there will be an email with the survey for the evaluations. Please look at that and fill that out. And we won't have grand rounds next week, I believe, because we are having a meeting. We'll be resuming with grand rounds the week after. Thank you.
Thank you. Thank you so much for inviting me and everyone's attention.
Bye-bye.
And feel free to reach out either by email or on Twitter.
We will. Thank you.
Thank you.